Let me unmute myself. Hello, everyone, and welcome back to Public Health Modernization Chats for June. My name is Heather Redman. I use she, her pronouns, and I am the Strategic Initiatives Partnerships Coordinator within OHA's Public Health Division. It's a lot of words, but what that means is that I get to hang out with all of you every month and talk about all things public health. So I would first like to just say Happy Pride Month, everyone. We've officially made it. And want to recognize that while it is not necessarily the entire month, but that we will be honoring and celebrating Juneteenth later on in June as well. And keeping in mind that all the work that we do is directly related to making sure that we are eliminating health inequities and that we are recognizing that systemic oppression has a direct impact on public health. So gentle reminder and also celebratory vibes for everyone here today. For anyone who may not be familiar with that song, it is Chapel Roan's Pink Pony Club. And it's great and they're awesome. And I highly encourage you to check out their music. We are here today to talk about housing as public health. And we have a very special guest speaker, also from Oregon Health Authority, also named Heather. So you're getting two Heathers today. Heather Blake is here with us, and I am going to very quickly turn it over to her in a second to start sharing her slides and start our conversation. And per usual, we'll have a warm-up question, and that is, what is something that you are looking forward to celebrating this month in June? Anything at all, whether it coincides with celebrations that are already happening, or whether it's something personal to you. So if you wouldn't mind introducing yourself in the chat with your name, pronouns if you choose to share them, where are you coming to this meeting from? What work do you do? And what's something that you're really excited to celebrate? I will share for myself that I am finishing my master's degree and I graduate next week. And so I am very excited. Thanks, Jamie. I am very excited to have a celebratory month for myself around this really big accomplishment, among many other things to celebrate. So please go ahead, share in the chat. While that's happening, I'm going to pass it over to the other Heather, and she will get us started. Go for it.
Hey, hello everyone. As Heather mentioned, my name is also Heather Blake. I use she, her pronouns, and I am in the HIV, STD, and tuberculosis section in the Public Health Division of Oregon Health Authority. I wanted to start before sharing slides of just a little more introduction of myself and my role. And before that, wanted to just acknowledge that this month and the past few months and year have been difficult and challenging for public health. I know a lot of you are doing work on the ground, and those of us doing work in the state as well are concerned about the potential of programs and funding changing and potentially being cut and how that impacts the communities we serve. And I'm going to talk a little bit today about funding that is also being reduced, not as a result of the current administration in particular. But, as I'm talking a little bit in a scarcity mindset and about things that we need, I also just want to acknowledge that I understand there are a lot of needs and a lot of sometimes, unfortunately, needs that feel like they're in competition with each other, even though if they were all met and we didn't have folks that were oppressed or looked at as other or less deserving of things like housing, we would feel like we were less in competition and that our services and programs were all supporting each other and the communities in Oregon that most need them. So I just want to acknowledge that I understand and can feel the space and share the space that many of us are in. I also want to say I'm a white woman. I grew up in San Francisco. I have had a lot of privilege and I have not myself struggled with housing instability or a serious health conditions such as HIV or the others I'm going to discuss. And though I have done a lot of work in case management and on the ground, working with varying populations across the country and a little bit out of the country, I've never worked on the ground in Oregon. I started at the Oregon Health Authority in 2018, and I have been in this same role, HIV and tuberculosis community services manager, since I came to the state. So there is still a lot I don't know and have not experienced. And with all that said, I welcome you throughout my presentation and definitely in the discussion after, to interrupt me, not only to ask questions, but even to make corrections or additions to what I'm saying, either in the chat, which I may not see, or you can unmute yourself and just say, wait, Heather, I want to say something, especially if I'm using pronouns or any language that is confusing. I've been in presentations where like you're stuck on something that someone said way back here, and then you just like can't get up to speed with where they are because you still kind of feel lost. So I don't want anyone to be in that space. And I don't need to hear myself talk for 45 minutes. I hope not to. Um, Also, I can talk fast, so feel free to interrupt me and ask me to slow down. I will not be offended. Um, I think I'm gonna share my slides, and Zoom kind of changed the way sharing looks so that I can't usually see people when I'm sharing, but let's see. Hopefully you can see my screen without any like people on the screen, just the slides. Okay, I do see a thumbs up. I can see 4 people, so that's great. That's centering. Okay, so my presentation is called Housing for Public Health. Here we go. Is it gonna show? Okay, I went to slideshow mode. I'm clicking the slide here. Maybe if I just click there. Okay, yay. This is what we're gonna discuss. I'm gonna talk about housing being healthcare, the necessity for healthcare and overall health, why housing is also public health. So it's important not only for individuals, but for the community. And I'm gonna concentrate specifically on people living with HIV in rural Oregon, people with TB disease, pregnant people with syphilis, and also people with hepatitis C. These folks don't necessarily need housing more than other communities, and I'm sure their identities are going to intersect with many other groups that folks serve, but I'm going to present some data and information about programs and services and gaps specifically about these folks as examples. Discuss some challenges in leveraging Oregon's existing housing services, of which there are many, but they are pretty, I'll talk about the challenges, but they're not super centralized and they can be very confusing to navigate, as I'm sure many folks have experienced. And then we'll discuss, as we have time, opportunities to increase immediate, short-term, and long-term housing access for people with communicable disease. I didn't add a slide with discussion questions. I apologize, but I'd like people to think throughout my presentation about additional challenges that they may have experienced accessing housing for people that they work with, and also things that have worked. Which housing systems have you worked with? And that can be like a system, like working with a community action agency, or a specific like situation where you called a CCO and you got this one person that was amazing and they got you flex funds to keep this person's rent paid for the next couple months. So if anyone has examples of challenges or successes, I would love to discuss those at the end, as well as any other questions that arise or ideas or inspiration. So housing is healthcare. Safe, decent, affordable housing, as I'm sure everyone on this call understands, can allow people to prioritize medical care and also engage in medical care, meaning going to appointments, taking medications, being able to even keep an appointment in your mind or know what day or time it is, or be able to get to an appointment. If you have a place to shower and to sleep and to keep your belongings safe and your body safe, you can actually think about things that are, for lack of a better term, higher level needs, and be able to organize and attend to health needs. And then housing is public health as well. So Being housed, if someone is living with a communicable disease, them being housed allows them to follow up with medical appointments, like I stated, and complete treatment. If someone is living with tuberculosis, for example, and they need to be isolated in order to not expose others, they need to be housed and in a stable place in order to be isolated. And when people are able to treat and follow up on treatment, for HIV specifically, if they are taking medication as prescribed and able to have blood draws and their labs show that their HIV is undetectable, which is very likely if they're able to take medications as prescribed, they cannot transmit HIV to their sexual partners. So we use the term, and you might see billboards around the state that say U equals U. That means that undetectable equals untransmittable. This is a huge public health realization and finding and discovery in the past 10 years. And basically being on medication is prevention. So you're treating folks, you're also preventing the ability to transmit to others, in addition to the person themselves being able to have the same life expectancy as someone who doesn't have HIV if they are virally suppressed. And then people with TB, syphilis, and hepatitis C can be cured. So they cannot transmit any of these viruses or diseases to other people once they are cured from them. Reinfection also of the individual who has been infected is prevented if housing is stable. And financially, healthcare spending can be optimized because we all know that people are less likely to go to emergency services or urgent care if they're housed and stable and are able to shower and sleep. They're less likely to get infections and to get sick. They can also enroll in stable insurance and be found when people are trying to outreach and coordinate services. Again, if I'm missing anything, feel free to interrupt. So I'm going to focus on here people who are living with HIV. They rely heavily on housing supports. In Oregon, we have a program called Oregon Housing Opportunities in Partnership, which is actually the direct service providers who work with clients are state employees in this program, which is pretty rare that the state employees are the direct service providers, but we have 5 housing coordinators across what we call the balance of states, so the 26 counties outside of the metro area. And they serve about 150 to 200 people a year, or households per year, with housing supports. In 2023, which is our most updated data, 92% of OHOP clients were virally suppressed. So I spoke earlier about viral suppression, meaning that HIV is basically undetectable in a blood test. And if you're undetectable, you're untransmittable, and you are still have HIV, but you're living a pretty healthy life and you can't transmit HIV to other people. Nationally, people living with HIV are about 65% virally suppressed. So that's 65% nationally, regardless of housing status. Our specific housing program, compared to that, 92% of people are virally suppressed. So incredibly successful. And our clients are thriving even beyond viral suppression. I actually do want to take a little break from my voice and share a client's story. If this doesn't work, we'll share the slides so that you can listen on your own. It's just a minute long. Of course, now. Yes, okay, it's coming. And raise your hand like Heather or Sarah if you guys can't hear it.
Hi, we're a grateful OHOP family. We've been given life-changing help from OHOP for over 5 years. Throughout those years, we've been able to make progress and gain stability by attending school, becoming employable people, and worthy tenants.
Most importantly, we have been able to be present parents, maintain our sobriety, earn college degrees, and even work towards our next goal of homeownership.
Without OHOP, we would not have had the opportunities or securities necessary to rebuild our lives. OHOP has given us the chance to improve ourselves as parents and people of our community.
We cannot thank OHOP enough for the life-changing impact they have had on our lives.
From the bottom of our hearts, thank you, OHOP, for helping us cultivate the lives we did not know we could have.
So this couple actually asked if they could, oh my gosh, no, don't close. Actually asked if they could share this story so that we could share it to others. Sometimes it's uncomfortable asking clients to share their story. Yeah, there's a lot that kind of goes into that. But they had asked to be recorded and wanted to share and really wanted people to know how successful and important the program was to the state. They also now live in a Habitat for Humanity home and are just really amazing, as are so many of our clients. But I thought their voice was important to share. Overall, in a client satisfaction survey a couple of years ago, 95% of clients rated the program good or excellent. Um, and though most folks in general did report a higher rate of housing situation improvement when they were, from OHOP support, we noticed when looking at those surveys that Black, Indigenous, and other people of color had a little bit higher rating of housing improvement. And we think that that's important. We especially want folks who have a harder time navigating and accessing services, not due to their own inability, but due to stigma and oppression. We want equity in our services and want BIPOC and other populations that are historically oppressed and currently oppressed to gain the most. Additionally, this last bullet, 89% of clients who were in the program in 2023 remained in the program in 2024, so they remained housing stable. And of those who exited, 76% transitioned to permanent private housing. So we're keeping folks stably housed in our program and supporting them to transition to stable housing as well. And I does not want to advance, sorry.
Hey, Heather.
Yeah.
Sometimes on this particular slideshow share mode, if you go down to the bottom left corner, there'll be buttons that will appear at times. That was my suggestion.
Okay.
And sometimes you just need to click on it again, like
Yeah.
to kind of like re-engage it after sharing the audio.
Yeah. I keep.
Or maybe unshare and reshare.
Y'all unshare and share again. Sorry, y'all. Okay.
Heather, this is Dolly. I wanted to let you know that I think Zoom goblins are in the universe today because I had issues in a meeting previously. So, no, it's not just you.
Okay. Thank you. Okay, I reshared. To advance. I might have to just share my other screen that doesn't show it as like shows the preview on the side. I don't know why it doesn't, nothing else is coming up as options. This. Gosh, okay. Okay, it's okay. Tell me how, I wonder if I share instead of, oh, okay. No, because if I share my screen itself, then you'll see. Yeah, okay. I can just try to share my screen itself and close this. And then you're going to see Dolly's name because she spoke last. But that still doesn't work. Oh, God. Okay. Oh, did that not even work when I said you'll see Dolly's name? Did I not actually press share? Maybe that was
Yeah, nothing popped up.
okay.
So
Now
something is coming up.
Okay.
There we go.
Still, I'm not, okay. Did you see the slide advance?
Yes.
Okay, so you're seeing the one with the preview on the side?
Yes.
Okay.
Mhm.
Is that like viewable?
Yes,
Okay, whatever. We'll just go with that.
we
Um,
got you, Boo.
okay, thank you. So it's important I really want you to understand how successful this program is, as well as how dedicated our staff are. I saw one of them on the screen just when I was in the other view for a second. Um, to know that funding is being cut for people living with HIV in rural Oregon. So we found out, again, this was last year, that due to a change in legislation and a change in the way eligibility is calculated for a specific funding formula, we are no longer going to receive, at least in federal fiscal year 2026, our formula budget, which is about 750,000 a year. It usually goes up a little bit each year. We've received this formula funding since 2005. And this legislation called Modernization, separate from our modernization in Oregon, was passed federally in 2016 that said as of 2026, jurisdictions have to have at least 2,000 people, 2,000 living cases of people living with HIV in the jurisdiction that's receiving funding. And I use the quotes if you're able to see the picture of me, living cases, because living cases is defined as people who were as county of diagnosis or place of diagnosis. So if someone was diagnosed in Coos County, but is now still living with HIV in Greece, they count as an Oregon case. But if they were diagnosed in Boise and now live in Ontario, they're counted as an Idaho case. So even though with current numbers, our numbers are 23 living cases below the threshold of 2,000, there are over 2,700 people actually living with HIV in the same jurisdiction if you look at county of residence or place of residence rather than place of diagnosis. And I know that's kind of in the weeds, but I think it's really important for people to understand that we're not losing this money because there is not a need or because there are less people with HIV in Oregon. We're losing it because of a formula that was developed federally that we have not been able to understand the rationale for. So we're not going to be getting this 750 plus thousand a year. There are more people living with HIV who need it. These numbers are actually increasing in the balance of state in Oregon. And across the state, more than 20% of people who are diagnosed with HIV state that they are unstably housed. So there is a high need. I'm going to move on to tuberculosis. There's a link in here. You'll get these slides to the tuberculosis dashboard from 2024, which shows that 14 people diagnosed with TB were unstably housed in 2024. This is about, I don't want to misstate it. I didn't include those notes. 16%. I didn't have the notes because the number's on the slide. So 16% of people. So again, people with TB, when I tell people I work in TB, people frequently say, like, that doesn't really exist anymore in the US, right? There are still people living with TB or who get diagnosed with TB in Oregon and across the country. Those numbers actually increased in 2025. We were closer to 90, although historically we've been between 70 and 80% in the last 80 people in the last 10 to 15 years. But 16% of those folks are unstably housed. In the HIV, TB, and STD section, although our CDC cooperative agreement isn't very much money, it basically can pay for our 3 staff salaries, and that's it. We have prioritized general fund to pay for housing for people with TB while throughout the duration of their treatment, or at the very least while they are on isolation, so that obviously for their own and for public health, when they're very sick, they're isolated and stable. And for people who work, we want to incentivize and make sure that they stay on isolation and have enough money to meet not only their rent needs, but also we can pay for utilities and phones and food. and other immediate needs to support people in being able to stay at home. Of course, those are state general fund dollars. We're not always guaranteed to have what we have had across the section. And, we have made difficult choices to maintain TB funding because we see that besides the increase in 2024, which was actually seen across the country in TB, our numbers have remained pretty stable compared to other states historically. And we believe that because we house people while they are in treatment, we have reduced transmission of HIV significantly. We would love to have funding that's more stable than our own section general fund. And it costs about $170,000 a biennium to house people with TB. So a decent amount of money, but in the grand scheme of state funding and the amount of money that's spent on housing, it's not a lot. TB housing is also an equity issue. As I said, besides kind of the increase in 2025, we usually have 70 to 80 people diagnosed with active TB in a year. Up to 80% self-identify as a racial or ethnic group other than non-Hispanic white, and incidence rates are 80 times higher in Oregon among Native Hawaiian and Pacific Islander folks. 16%, as I showed earlier, are also homeless or unstably housed. So serving people with TB is also serving people who are significantly underserved and under-resourced in other places across our state. TB housing is essential. So in addition to ensuring that people remain isolated, we need to make sure that when they're infectious, we need to make sure that people are on directly observed therapy, which means that someone from the local public health department visually sees someone take a pill as prescribed, usually every single day. They're not always going to their home to take that pill. Sometimes video directly observed therapy is allowed, but frequently they do need to meet patients in person. They do need to provide medication at a regular duration, usually weekly. Sometimes that varies. Again, it's essential for people to be able to be isolated, to be able to adhere to and complete treatment. If people don't adhere to or complete treatment, they can develop drug-resistant tuberculosis or even multi-drug resistant tuberculosis, which can be transmitted also as that drug-resistant strain. So the more people who get it, the more people can get it. And it's extremely complicated for an individual's health and extremely expensive to treat. Having someone housed and stable not only supports public health being able to observe them taking medication, but also in conducting case investigation and follow-up, testing people in the household, for example, and making sure that they get on treatment, whether they have active TB or even latent tuberculosis. So overall, this can stabilize case rates.
Hey, Heather.
Yes.
Yeah, you said interrupt you if there was a question, and one popped up in the chat. So Lori wants to know, or says, your stats don't include age. Do you collect age-related data, or can you point us to someone who does?
We do, and when these slides come out, please check out the tuberculosis dashboard. You should actually even be able to Google it, like tuberculosis OHA dashboard. It's on Tableau, and it has a few different tabs, including, multiple demographics, including age. Thanks for that question. Last thing, we have not only been able to keep our case rates pretty stable, but we've been able to avoid legal interventions across the country. If someone is not in isolation, it is a requirement that they're put on a legal hold and that they're legally mandated to isolate themselves, and that can be very complicated and very costly and very traumatic. And we have been able to avoid that because we offer services to keep people stable and healthy and supported while they're in treatment and needing to be isolated. Again, TB housing dollars are temporary, and TB housing itself is temporary. So although it's wonderful that we're able to support people financially so far with our general fund, while they're on TB treatment. Once their treatment is complete, we no longer have those funds available through HST, through the HIV STD tuberculosis section to house them. And so unfortunately, many of them return to homelessness. And we have been working, supporting local public health the last few months in linking them to other housing resources across the state. But local public health folks are not social workers. As many of you are likely on the call, they are extremely overworked and can barely have the capacity to do the minimum clinical statutory requirements. And so navigating our extremely complex housing system in Oregon is not really something they have the capacity to do. And the people that local public health tends to serve are also people who are going to face a lot of challenges following the requirements of getting through the housing system, such as checking in on a weekly basis, making a call every day, knowing where they are on the wait list, even filling out the application, etc., having the documents necessary to get on the wait list. Okay, I'm moving from TB to syphilis, specifically pregnant people with syphilis. And again, there are dashboards with much more information about STIs or sexually transmitted infections overall, and congenital syphilis and pregnant people with syphilis. Syphilis specifically is syphilis in newborns. And so we look at data around pregnant people with syphilis to understand the risk of congenital syphilis, because if syphilis is treated in a pregnant person, it will not result in congenital syphilis. And as despite the huge efforts of our STI program and work that they've done with clinicians and other groups, adolescent and reproductive health, we have seen an increase in congenital syphilis. The outcomes for congenital syphilis are not good. One of the outcomes potentially is stillbirth, and if people live with congenital syphilis, they have many complications. And unstable housing, not surprisingly, threatens health outcomes. So from 2019 to 2024, again, more of this data are on the dashboards, but 34% of pregnant people with syphilis were unhoused or unstably housed. And 49%, or almost half, of pregnant people linked to a congenital syphilis case were unhoused or unstably housed. So likely that someone who is pregnant with syphilis is also unstably housed. And we see even more likelihood of that in a congenital syphilis case, so that it's extremely important to have housing for pregnant people with syphilis. And this is something we actually don't have dedicated funding for in our section, and something that we are hoping and trying to change. I have a little glimmer of hope in my next slide. Outside of HST and at a higher level at the Oregon legislature, there is a package of bills called Momnibus 2025. Again, there's a link here. I encourage you to check it out. And there's a few different bills in that package, but one of the bills, Senate Bill 690, focuses on housing stability for pregnant and postpartum individuals. So in Oregon, going through any of our housing systems, there is no prioritization for someone who's pregnant. So if you go in and you have children and you have a family, you will likely get housing faster than a single person. But if you are pregnant, you have no prioritization over someone who's not pregnant to be housed. And Oregon ranks worst in the country, #1, for unsheltered homelessness among children. Obviously, if we were able to house and stabilize people who are pregnant, we would have less children who are homeless as well. And so this package of Momnibus bills, especially this bill, 690, is working to end that and improve that in Oregon. Unstable housing, oh, wrong direction. Okay, moving on to hepatitis C. This is my last example or specific condition to talk about, and then I'd like to have more of a discussion. I'll stop sharing my slides and I can see you all. So as does housing for all groups that I mentioned, and really all people, housing people with hepatitis C saves lives. So I remember we were first in the nation for homelessness among children, and we are third in the nation for hepatitis C related mortality. And among people that have died from hepatitis C, there are significant disparities. And so we can see that the rate of death among Black and African American people, American Indian and Alaskan Native, and white Hawaiian and Pacific Islander people greatly exceeds those of other races and ethnicities. So this as well is an equity issue. We have had some success in getting folks with hepatitis C, I think due to the Prime Peer Network and other hepatitis C specific programs across the state linked to CCO and other funded housing services. And those folks have been linked to substance use treatment and maintained stable housing. That's more anecdotal information from the hepatitis program, but we know that when access to housing is there, people can stabilize and be healthy and prevent reinfection and prevent transmission as well. Again, there is no dedicated funding in the hepatitis C program, nor in our STI and syphilis program specifically for housing. This is a gap, a huge gap within our system. So this is the list of housing resources that I and HST are aware of that exist outside of dedicated funding like our HIV housing program that I mentioned and our kind of money that's set aside for TB housing. These are the systems that folks from the public can generally access to receive housing supports, and they are not centralized. It's not always clear whether it makes more sense to go to Medicaid, which provides health-related services, or also provides Medicaid waiver funding, HRSN, or to go to a continuum of care, which is different in every county, or kind of there are counties grouped together. There are 5, I think, continuums of care just in kind of the balance of state outside of the metro area. And there are 19 public housing authorities in the balance of state metro area. So when we've tried to reach out to kind of create partnerships and clarify, like I mentioned earlier, how public health folks getting a clear roadmap was different for each county and was super overwhelming, even for OHA staff who have a lot of knowledge of the housing system to support local public health staff in understanding and accessing. In addition to money that comes through federal and state government to Medicaid that goes to HRS and HRSN, federal HUD, housing and urban development money goes specifically to continuums of care. This is like the coordinated entry system where usually if you're homeless, you enter, you kind of have an assessment, you get a priority, and then you might go through the shelter system before you're eligible for some kind of longer term or intermediate housing. So federal money goes to the continuums of care, and there are opportunities. Oh, this was supposed to be updated to community action agencies. And then there are also money that comes through this from the federal government to the state that then goes to community action agencies for housing. It's kind of unclear if you should go to a community action agency, if you should go to a COC. Sometimes those entities also fund the same nonprofits. So if you go to one nonprofit, can you be linked to all the housing resources? Unclear, unsure. And then there's the public housing authorities, which are also county by county for the most part to access housing choice voucher, currently within the balance of state, so outside of the metro area, which is more my expertise. All of those housing lists are closed. It's not possible right now today to get on any of those wait lists. And then there has been special initiative funding through the governor's office that has gone to yet another set of groups that prioritize funding called MAC groups, which I'm blanking on the acronym of, and LPGs or local planning groups. There's a landlord guarantee program where if somebody has Section 8 or has received rent through special initiatives funding, the land and has left their unit with damages that exceed the deposit, those landlords can go through the landlord guarantee program to recoup the money that they lost in damages. So that's an incentive for a landlord to house someone with a housing choice voucher or through these special initiatives funding. But if they're housed through our OHOP program, for example, or through TB housing, the landlord guarantee program is not available to them. And then one thing that has been successful, it doesn't increase the amount of money we have to house people, but our HIV housing program has partnered with low-income housing developers to have preferential units and a kind of friendly, collaborative, in most cases, relationship with the developers and the on-site staff um, to support housing stability for those clients. But it's a very complicated web. And so I would love in the 13 minutes we have left to talk about any other ideas that people have for housing or successes they have, or any other questions that have come up during my talking. And I can keep this up or stop sharing if people want to just chat for a while. What do you think?
Thanks, Heather. I think I'll just kind of kick off a framing that I think will be helpful for the questions and discussion. Amber just shared something in the chat, or just reminding folks that housing wait lists are also difficult because they may or tend to have specific open times. And the example they provided was, for instance, in Lane County, the Section 8 wait list opens for 1 week for a lottery to pull households. They're assigned a number, and then it closes again for approximately 3 years. And so going back to the your very first slide of like how housing is public health, and I hear in that sharing, what I'm gathering is that we're in the many places we tend to be, is that we're doing the best we can with the systems that we were handed while trying to improve them and change them from the inside. And while we are trying to do that work, people are not getting their needs met. And that's a really, can be really challenging two truths to hold at the same time. But I also just wanted to share that with the group, share that with you, and see if anyone has any other questions, reflections, or thoughts around all of the amazing information that you shared with us today.
If I could just pony on my own comment real quick. This is Amber. I think one of the really difficult parts when we're talking about like trying to help the LPHAs get people in for TB housing or that sort of thing is that not a lot of people have case management on an ongoing basis. And so when these things are opened up, it's really difficult to make sure that the information is getting out to all the folks that might need it and kind of anticipating that the need might be there. And so when people aren't kind of connected to a system, it can be difficult to share that if we get them just for like a point in time, like this period of time we're working with them. And so I do try really hard to get people to sign up with the actual housing authority. They can express an interest and get emails from them. And so it is kind of an issue of like, if I only have 5 minutes, how do I best help you figure out how to navigate the system on your own when I am being paid to navigate the system on a daily basis, right? So like it's a big job to do. So I guess I just want to acknowledge that like where I see some support coming is kind of figuring out how to waitlist folks or, you know what I mean, create some kind of listing or like information sharing that can happen, and how to navigate the system for folks for the limited resources that exist. So we've got a money issue and then we also have an inventory issue. And it's so important. So just sharing that.
I'm going to piggyback off of that. I'm Taya, and I am the the housing outreach peer navigator for Providence Hospital. And so I have the same sort of issue, right? So I meet people out in the community, like who are camping or, just uh, getting them to a shelter or something like that. And so a lot of times I'll get connected with someone and I'll get connected for maybe like 3 days. And then someone might even, get picked up by or arrested or something like that. And I'll get them because they came through the ED. And so I know this information, and then they leave and they leave and they lose their insurance or something. And it's really difficult to follow them because they don't necessarily pop up in our system again. And so I try really hard. Like even today, I called an attorney because I know that my one of my people is got picked up over there and they're somewhere in that system. And I just want them to know this information about them, right? Because I'm just trying to make sure that somehow this information follows this person into another county. And so it's just the same as you, right? Like, how do we help that client and that person have that information follow them when there's not really a system that we can just like, you know, organically have it follow them? Because that's not really there. And so it's hard when you only get them for, like you said, 5 minutes. And sometimes they're not cognitively able to do anything on their own like that. Like they're not um, having the ability, they're not in um, the same consensus reality that we are. So that's really difficult.
And it's super difficult to forward think when you are surviving in the moment, right? So in the moment, I have this huge issue that's happening, and I can't think about 3 years from now, the wait list is going to open up again, and I need to get on the wait list to make sure my emails, blah, blah, whatever. That's not, you're really in a point of just surviving. So, um, but housing is so important, and we see such good results when we have the ability to support people in that.
Amazing. Thank you both for sharing. I think that what I'm being reminded of in this conversation, especially with Heather's call out of that, there was like a federal formula that was designed, and now we don't really know that it's working, or we know that there's room for improvement. And so I'm thinking about all the ways that historically as well, and we're talking about inequities across time, that the people that are making the decisions for the people who have the lived experience, and how that has been a pretty consistent disconnect, and that there are so many people working in systems trying to rectify that the solutions that are prescribed to folks that are trying to navigate a challenge or a problem, that disconnect is one of the things that makes it can make it a challenge in the first place. And I don't laugh to laugh it off. But just that sometimes I gotta laugh or I'm gonna cry and give up because it's really hard to change systems from the inside. So I just thank you both for sharing those pieces. And I do also see for Heather, there's a few other questions in the chat as well. And so I'm wondering if you can see the chat. I'm looking at time as well. If there's maybe one that kind of is feeling significant to you, or that you would like to answer or touch on. Also, Cecilia shared that not sure about the overlap, but the VA has supportive services for veteran families incentives for landlords. And so again, that challenge of like, is that information we know about the person that we're helping and supporting through a transition? And yeah, are they aware of that benefit if it applies to them, and do they know how to access it? Just really calling out the way that systems have been designed to not meet the unique needs of someone who is trying to access support through a system. I see that it's huge with the mental health system of like all the steps it takes to be able to receive professional mental health is not in line with the capacity and sometimes the capability, the energy that folks can dedicate to pushing through that system to access the care that they need. So I will pause because I'll just keep going. And Heather, do you see something in the chat that you'd like to touch on?
Yeah, in our HIV housing program, which is really the only established program I presented on that we have for housing people with communicable disease, we do screen for veterans and link to services. I don't actually know, other folks would at local public health if that's something that's screened for, and a referral that's usually made for outside services. If you know in public health, you can feel free to put that in the chat or speak on it aloud. Regarding tiny villages, I'm definitely not an expert here, and I don't want to misspeak about anything, but I do know that some of the tiny villages that are popping up across the state do not meet HUD's definition of safe and stable and habitable units. And so any federally funded program through housing and urban development, which is where most of those funds come from, cannot support paying for those tiny villages. So for private funding or people who have low income but some income, I think it's a great solution to be in a unit. Anything is better than a little bit of safety and security is better than no safety and security. And if someone is choosing to live in a tiny village or a fifth wheel trailer, for example, which also doesn't kind of pass that federal inspection criteria, our HIV program does have other pots of funding that can help pay for those temporarily while folks find other more stable housing. So I don't have a super insightful response to that other than the federal funds can't pay for them.
I think generally just speaking that housing is a spectrum, right? So there's a huge need in each category, and we get funded federally in like this small section of the huge category. And so being creative in how we think about funding and connections and collaborations along that spectrum and having the spectrum talk to one another is really helpful so that we can gear people to move through it if they can. And so that we're not constantly kind of reinventing the wheel, and that we've identified like who are the people that have information and who are the people that have money, and how do we get people to the right people, right? Because sometimes people just need to have that information and they need to have it a couple of different times and they're not necessarily ready for money, and vice versa. And generally when people are asking is in an emergent, I need money today situation, and we need to be thinking about that in an earlier style if we're working on government timelines, unfortunately. And Casey mentioned, and I thought about this too, Heather, for the slide, it might be useful to mention 211, just as far as a kind of a hub of information that people can go to for resources. But if you type in housing, it'll tell you anybody who's ever mentioned that they have housing as part of their support services they have, and that might be rent assistance on a one time or deposit assistance as a one time, but also will refer to some housing programs or utility programs to help people stay housed as well. And that might be part of the community agency piece that you were talking about, but that specifically as people, if we're providing that information to make sure that resource is updated, that can help keep information current, because that's the other piece. Once you get your tendrils out, you got to keep the information current.
Thank you so much, everyone. I'm aware of the time, and I just want to give Heather the opportunity, invitation only, no pressure. If there's any closing thought you would like to share with the group before I officially close us out and share what next month's topic will be.
I don't think I said this clearly. People who have an acute medical need like tuberculosis, hepatitis C, syphilis while pregnant, or syphilis period, can't wait go through that housing structure. They need funding to be housed immediately. And therein lies like the difficulty of all of our systems. It's not immediate housing. So whatever spaces folks are in and can talk about that need and want more information from any of our colleagues, I'm happy to share that. And I have their contacts on the slides as well that will be shared.
Amazing. Thank you, Heather, for coming today and for sharing about this information. It sparked a really meaningful exchange of ideas and just the intelligence and the experience that exists within this space, both in this conversation and in the chat. Please remember, or I say please remember that I will be sending a follow-up email to everyone. It will have the slides from today's presentation. It will have the recording and any other resources that were shared in the chat, as well as contact information for folks who might want to continue this conversation with the team at OHA. And I really hope that you all can join us again in July. We are actually going to have Sharina Walker come back, who is our policy lead in the public health division, to give us a legislative session recap. She was here in February to kind of help us learn how to navigate that system better and what are the ways that we could get involved with legislative session in 2025. And she's going to come back and let us know how it went. And I'll just leave it there. So please have a lovely June. Happy Pride. Celebrating and honoring Juneteenth later this month. And I hope that you continue to do all the good work that you're doing. I know you will. And if no one has told you yet this week or today, you're doing good work and you should be proud of yourself. So thank you, everyone. We will see you next time.